everyone, it's me again, Nurse Clary, and in this video I'm going to discuss about epilepsy and seizure. So epilepsy and seizure is under abnormal electrical discharge of the neurons in the brain. Previously, under nervous system, I was able to discuss about simple anatomy and tissue and neuro assessment, nervous system injury, which is about head injury and spinal cord injury. Right now, we will be discussing about abnormal electrical discharge of neurons in the brain, which is about epilepsy and seizures. So first, let's define epilepsy. Epilepsy is a central nervous system or neurological disorder in which brain activity becomes abnormal, causing seizures or periods of unusual behavior, sensations, and sometimes loss of awareness. Epilepsy is a chronic disorder, the hallmark of which is recurrent, unprovoked seizures. So a person is diagnosed with epilepsy if they have 2 unprovoked seizures or 1 unprovoked seizure with the likelihood of more that were not caused by some known and reversible medical condition like alcohol withdrawal or extremely low blood sugar. Next, let's define seizures. Seizures are abnormal movements or behavior due to unusual electrical activity in the brain. So they are a symptom of epilepsy. So therefore, seizures are only symptom of epilepsy, but not all people who appear to have seizures have epilepsy. So what are the difference between epilepsy and seizures? So when you say a seizure is actually a single occurrence, whereas epilepsy is a neurological condition characterized by 2 or more unprovoked seizures. It means seizure, it's like when there is, for example, there is a condition like extremely low blood sugar, then the patient has had seizure. If that condition is addressed, then seizures will be resolved. So that is seizure, a single occurrence. Now let's proceed with the simple pathophysiology. So of course, our brain has neurons. Neurons transmit information. And there are 2 types of neurons, inhibitory and excitatory. When you say inhibitory, from the word itself, it is stop an action or cause inhibition. It is through releasing GABA, a neurotransmitter. This is inhibitory neurotransmitter. While when you say excitatory neurons, it produced action or cause an excitement, and they are doing it by releasing a neurotransmitter called glutamate. So in normal brain, there are a balance of neurons of inhibitory and excitatory, so they are balanced. But with those who have seizure, there are imbalance of those 2 neurons, the inhibitory and the excitatory. So there are abnormal electrical discharge of neurons in the brain. So that is the simple pathophysiology of seizure. Now let's move on with the causes. So causes, anything that interrupts the normal connections between nerve cells in the brain can cause a seizure. So under that is high fever, high or low blood sugar, alcohol or drug withdrawal, or a brain concussion. While epilepsy, when a person has 2 or more seizures with no known cause, This is diagnosed as epilepsy. Sometimes there could be congenital brain defect, stroke, traumatic brain injury, long-lasting effects of an infection, but mostly it's unknown. Diagnostic tests. There are actually a lot of diagnostic tests like prolactin studies, serum studies of anticonvulsant agents, neuroimaging studies, electroencephalogram, video electroencephalogram or EEG, then lumbar puncture. Prolactin study, the American Academy of Neurology recommends serum prolactin assays measured in the appropriate clinical setting at 10 to 20 minutes after a suspected event as a useful adjunct for differentiating generalized tonic-clonic or complex partial seizure from psychogenic non-epileptic seizure in adults and older children. While the serum studies of anticonvulsant agents, judicious testing of serum levels of anti-epileptic drugs may help to improve the care for patients with seizures and epilepsy. However, note that many new anti-epileptic drugs do not have readily obtainable or established levels. While the neuroimaging studies, such as brain magnetic resonance imaging or head computed tomography or scanning, may show structural abnormalities that could be the cause of seizure. While when you say electroencephalogram, abnormalities on EEG strengthen the diagnosis of epileptic seizures and provide some help in determining the prognosis. Next is video EEG. Monitoring is the criterion standard for classifying the type of seizure or syndrome or for diagnosing pseudo-seizures, that is, for establishing a definitive diagnosis of spells with impairment of consciousness. Lastly is lumbar puncture. Detects abnormal cerebrospinal fluid pressure, signs of infections or bleeding as a cause of seizure activity, but this is rarely done. The most important diagnostic test here is the electroencephalogram. Now let's move on with the two main types of seizure. Number one is generalized seizures. Number two is focal seizures. So let's discuss first generalized seizures. Generalized seizures affect both sides of the brain. There are two types: absence seizures and tonic-clonic seizures. So absence seizures, sometimes called petit mal seizures, can cause rapid blinking or a few seconds of staring into space. While tonic-clonic seizures, also called grand mal seizures, can make a person cry out, lose consciousness, fall to the ground, have muscle jerks or spasms, and the person may feel tired after a tonic-clonic seizure. Next is focal seizures. Focal seizures are located in just one area of the brain. These seizures are also called partial seizures. There are three types of focal seizures: simple focal seizures, complex focal seizures, and secondary generalized seizures. Simple focal seizures affect a small part of the brain. These seizures can cause twitching or a change in sensation, such as a strange taste or smell. Complex focal seizures can make a person with epilepsy confused or dazed. The person will be unable to respond to questions or direction for up to a few minutes. Secondary generalized seizures begin in one part of the brain, but then spread to both sides of the brain. In other words, the person first has a focal seizure, followed by a generalized seizure. So seizures may last as long as a few minutes. Now, the phases of seizure. There are actually four phases, or sometimes they call this as stages of seizure. So first is prodromal phase, second is aura, third is ictal stage, and fourth is post-ictal stage. Number one, prodromal phase involves mood or behavior changes that may precede a seizure by hours or days. So the prodromal when symptoms start to appear prior to the seizure. Next is aura. Aura is a premonition of impending seizure activity and may be visual, auditory, or gustatory. Aura doesn't happen actually with all types of seizure. It could happen in the very beginning of the seizure for focal seizures or in a tonic-clonic seizure. So it could happen within seconds to minutes before a seizure. So many times it gives the patient time to prepare themselves for the seizure. So we need to help the patient lay down onto their side with a pillow under the head. And symptoms may vary among patients but can include sudden weird smell or feeling anxious like something bad is about to happen. While next is the ictal stage. It is characterized by seizure activity, usually musculoskeletal. And during this stage, this is actually the actual seizure. It usually lasts for 3 minutes, but you need to time the seizure during this time because seizures greater than 5 minutes, this is what we call status epilepticus, and we'll discuss that later on. So next is the post-ictal stage, is a period of confusion, somnolence, irritability that occurs after the seizure. So in post-ictus, the brain is resting and recovering from the seizure. Now let's define important terms that you might encounter with the exam. So definition of terms: non-epileptic seizures, called pseudo seizures, are not accompanied by abnormal electrical activity in the brain and may be caused by psychological issues or stress. However, non-epileptic seizures look like true seizures, which makes diagnosis more difficult. Normal EEG readings and lack of response to epileptic drugs are two clues they are not true epileptic seizures. These types of seizure may be treated with psychotherapy and psychiatric medications. So next is provoked seizures. Are single seizures that may occur as the result of trauma, low blood sugar or hypoglycemia, low blood sodium, high fever or alcohol or drug abuse. Fever-related or febrile seizures may occur during infancy but are usually outgrown by age 6. After a careful evaluation to estimate the risk of recurrence, patients who suffer a single seizure may not need treatment. Next is seizure disorder. Is a general term used to describe any condition in which seizures may be a symptom. Next is status epilepticus. This is a seizure that lasts longer than 5 minutes or having more than one seizure within a 5 minutes period without returning to a normal level of consciousness between episodes. So this is actually a medical emergency that may lead to permanent damage or death. So status epilepticus is very rare. Most people with epilepsy will never have it. This condition is more common in young children and elderly adults. So if convulsive status epilepticus lasts for 30 minutes or longer, it can cause permanent brain damage or even death. And we need to activate emergency response, and the first treatment for early status epilepticus mainly comprises the administration of benzodiazepines, the most frequently used of which include diazepam, lorazepam, and midazolam. Next is, these are the words used to describe generalized seizures: tonic, atonic, myoclonic, and clonic. So when you say tonic, muscles in the body become stiff, while atonic, muscles in the body relax, and myoclonic, short jerking in parts of the body, and clonic, periods of shaking or jerking parts on the body. So tonic, clonic, when you combine them, muscles in the body become stiff and there are periods of shaking or jerking of the parts of the body. Next is the signs and symptoms. Signs and symptoms varies depending on the types of seizure, if it is generalized or focal. So a person with epilepsy can have more than one type of seizure. So let's now move on with the nursing intervention. So the main goal of the nursing interventions are patent airway and the safety of the patient. So a thorough nursing assessment is very important, so we need to take the history and physical exam of the patient. So for the history, the diagnosis of epileptic seizure is made by analyzing the patient's detailed clinical history and by performing ancillary tests for confirmation, meaning someone who has observed the patient's repeated events is usually the best person to provide an accurate history. However, the patient also provides invaluable details about aurals, preservation of consciousness, and post-ictal states. So a physical examination helps in the diagnosis of specific epileptic syndromes that cause abnormal findings, such as dermatologic abnormalities like neurocutaneous syndromes such as Weber, tuberous sclerosis, and others. Also, patients who for years have had intractable generalized tonic-clonic seizures are likely to have suffered injuries requiring stitches. So, what are we going to do with the patient before seizure? So, before seizure, we should initiate seizure precautions. So, we should assess your patient for signs and symptoms of seizure activity, such as his report of an aura or twitching of muscle groups, especially in his face or hands. So, have an oral, airway, suction, and oxygen should be readily available. So, keep his bed in a low position, and there should be an IV access, at least two, and then side rails up and padded side rails, and then make sure that there is no object that could cause injury to the patient. Next is during seizure. So during seizure, we should protect the patient. Number one, we need to stay with the patient to protect from injury and observe for seizure activity. If the patient is on the chair or out of bed, ease him to the floor. Place a towel or folded blanket under patient's head. But if the patient is in bed, remove the pillows, raise the side rails, put the bed in the flat position, loosen any restricted clothing, and then clear the area of objects that could hurt the patient. Next is after seizure. After seizure, we need to assess for respirations and pulse, and if there is respirations and pulse but unresponsive, we can turn him to side to help keep his airway patent. So if necessary also, insert on oral airway and use suction to remove secretions. And we need to take vital signs. And if pulse or respirations are not present, we need to call for help and start CPR. Next is we need to cover him with a blanket for warmth and privacy. So after that, we need to perform a neurologic assessment, calmly reassure and reorient the patient, observe and document characteristics of seizure, and indicate if the patient reported an aura or if there are other signs and symptoms that he observed prior seizure. Now, let's move on with the don't. So, with the don't restrain your patient during a seizure because the strong muscle contractions could injure him. Number 2, don't try to open his clenched jaws or force anything into his mouth. Doing so could injure his lips and teeth and cause his tongue to obstruct the airway. Number 3, don't move the patient unless the environment is unsafe. Number 4, don't suction the patient or pharynx until motor activity stops. Now let's move on with the medications. Anticonvulsants or other, these agents prevent seizure recurrence and terminate clinical and electrical seizure activity. Anticonvulsants are normally reserved for patients who are at increased risk for recurrent seizures. 2 is anticonvulsants barbiturates like benzodiazepines. Barbiturates bind to the gamma-aminobutyric acid receptor, enhancing the actions of GABA by extending GABA-mediated chloride channel openings and allowing neuronal hyperpolarization. So earlier I discussed it in my simple pathophysiology regarding the GABA or the inhibitory neurotransmitter that is being released by inhibitory neurons. That is since there is an abnormal or imbalance of this, so phenobarbital is being used. So barbiturates or phenobarbital used for tonic-clonic, focal seizures, and status epilepticus. So side effects: drowsiness, uncoordinated movements known as ataxia. So we need to watch out for respiratory depression and hypotension. And the drug level should be 15 to 40 microgram per ml. So next is anticonvulsants, benzodiazepines. These agents bind to the gamma-aminobutyric acid receptor or GABA, thereby enhancing the actions of GABA. So benzodiazepines, they are used with absent seizures, tonic-clonic, or focal. And diazepam or lorazepam, they are more common for status epilepticus because they are fast-acting, and the patient may be very drowsy, and tolerance can develop, and there could be impairment of the liver, so we need to monitor the liver studies. The reversal agent or the benzodiazepine antagonist is flumazenil. This is the primary FDA-approved clinical uses for flumazenil include reversal agents for benzo. So specific benzodiazepine antagonist is useful in reversing the sedation and respiratory depression that often occur when benzodiazepines are administered to patients undergoing anesthesia or when patients have taken an intentional benzodiazepine overdose. Next is anticonvulsant succinimide. These agents reduce current in T-type calcium channels. Next is anticonvulsants neuronal potassium channel opener. stabilizes neuronal channels in the open position, increasing the stabilizing membrane current and preventing bursts of action potentials during the sustained depolarizations associated with seizures. Next is anticonvulsants, hydantoins. These agents stabilize sodium channels and prevent the return of the channels to the active state. So hydantoins or phenytoin, they are used with tonic-clonic or focal seizures. So we need to watch out for gums because it will enlarge and easily bleed. So called gingival hyperplasia. So we need to teach the patient on how they will brush their teeth. Next is may cause bone marrow suppression. So we need to watch out for platelets and WBCs. We also need to watch out for rashes and report it to the physician. And we should not give milk or antacids along with this medication because it could interfere with absorption. So the therapeutic level is 10 to 20 microgram per ml. Next is valproate or valproic acid. They are used for absent seizures, partial seizures, and generalized seizures. This can cause serious birth defect and can also lower intelligence and problems with movement and coordination, learning, communication, emotions, and behavior in babies exposed to valproic acid before birth. So we need to tell the doctor if the patient is pregnant or plan to become pregnant. And aside from that, for all types of the medications, we need to monitor the liver, WBC, and platelets, as well as any GI issues. Next is medical management. So, to achieve a seizure-free status without adverse effects. So, that is the goal for the medical management. So, there are a lot of medical management: monotherapy, anticonvulsant therapy, discontinuing anticonvulsant therapy, ketogenic diet, Atkins diet, vagal nerve stimulation, implantable neurostimulator, lobectomy, lesionectomy, activity modification restrictions, and long-term monitoring. So let's start with monotherapy. So when you say monotherapy, it is desirable because it decreases the likelihood of adverse effects and avoids drug interactions. Also, monotherapy may be less expensive than polytherapy, as many of the older anticonvulsant agents have a hepatic enzyme, including properties that decrease the serum level of the concomitant drug, thereby increasing the required dose of the concomitant drug. So next is the anticonvulsant therapy. Anticonvulsant therapy, the mainstay of seizure treatment is anticonvulsant medication. The drug of choice depends on an accurate diagnosis of the epileptic syndrome, as a response to specific anticonvulsants varies among different syndromes. So next is discontinuing anticonvulsant therapy or agents. After a person has been seizure-free for typically 2 to 5 years, the physician may consider discontinuing that patient's medication. Many patients outgrow many epileptic syndromes in childhood and do not need to take anticonvulsant. Next is ketogenic diet. The ketogenic diet, which relies heavily on the use of fats such as hydrogenated vegetable oil shortening. This diet is unquestionably effective in some refractory cases of seizure. A ketogenic diet is difficult to maintain. Less than 10% of patients continue the diet after a year. Next is the Atkins diet. Preliminary data have been published about improvement of seizure frequency following a modified Atkins or low carbohydrate diet that mimics the ketogenic diet but does not restrict protein, calories, and fluids. In small studies of children with intractable epilepsy, seizure reductions of more than 50% have been seen within 3 months in some children placed on this diet, particularly with carbohydrate limits of 10 grams per day. Next is vagal nerve stimulation. VNS is a palliative technique that involves surgical implantation of a stimulating device. It is FDA approved to treat medically refractory focal onset epilepsy in patients older than 12 years old. Some studies demonstrate its efficacy in focal onset seizures and a small number of patients with primary generalized epilepsy. Next is implantable neurostimulator. So, implantable neurostimulator, the NeuroPace RNS system, a device that is implanted in the cranium, senses and records electrocorticographic patterns and delivers short trains of current pulses to interrupt ictal discharges in the brain. Next is lobectomy. In a randomized controlled trial of surgery in 80 patients with temporal lobe epilepsy, 58% of patients in the group randomized to anterior temporal lobe resective surgery were free from seizures, impairing awareness at 1 year, as compared with 8% in the group that received anticonvulsant treatment. Next is lacunoectomy. In a study presented at the 66th Annual Meeting of the American Epilepsy Society, investigators suggested that in selected pediatric patients, smaller lacunoectomy resections in the surgical treatment of seizures may be as effective as larger resections, and they may spare children the functional and developmental deficits associated with the larger resections. Next is the activity modification and restrictions. The major problem for patients with seizures is the unpredictability of the next seizure. Clinicians should discuss the following types of seizure precautions with patients who have epileptic seizures or other spells of sudden onset seizures. Driving, ascending heights, working with fire or cooking, using power tools and other dangerous equipment, taking unsupervised baths and swimming. Lastly is long-term monitoring. In 2018, the FDA cleared for marketing the first smartwatch for seizure tracking and epilepsy management. The Embrace smartwatch identifies convulsive seizures and sends an alert via text and phone message to caregivers. The watch also records sleep, rest, and physical activity data. The device was tested in a study of 135 epileptic patients and found the watch's algorithm detected 100% of patient seizures. Thanks for watching! If you like this video, don't forget to hit on like and subscribe on my channel for more videos. On my next video, we'll now discuss the autoimmune diseases under the nervous system, which is MS or multiple sclerosis, GBS or Guillain-Barré syndrome, and Alzheimer's disease. Thank you again, and bye for now.